Oops, get away from the camera.
Yeah, don't knock it. That's better.
It's better. It's good, isn't it?
Like you can see that.
That works.
We're on microphone now on Teams, so people will hear.
For being back so promptly. The next section comes about. It's a bite-sized section. It's a nightmare to manage, but we'll see where we go. And this is made up of people that are wanting to get their presentations and their projects over. We went through huge amounts of people who wanted to present at the plenaries this year, and it took a lot of decision making to get to where we've got to today. And so what we decided to do again is to do the bite-sized presentations. So it is imperative, those that are speaking, that we stick to time. If I have to, I'll help you do that. And it's written on my sheet here in capital letters with an exclamation mark, keep to time. So we'll kick off then with Lisa and Nicole, if that's okay. Because and then if we could, as we're finishing off that one, Matt, if you could rev up and be with us ready to go on that one. And then Fran and Amy after that, and then Joseph after that. Is that okay? I just want everybody to be ready and ready to rock on that. So Lisa Kinsella and Nicole Cummings, who are both lecturers from Aberystwyth University. Green Gatherings. Over to you guys.
Thank you for the clap. Good afternoon. My name is Lisa Kinsella. I'm a lecturer in mental health from Aberystwyth University. And before I hand you over to my colleague, I'd like to say thank you very much to the caterers for such an absolutely stunning lunch. That was really nice. Thank you.
Hi, lovely to see so many faces. Okay, so my name's Nicole Crimmings, and I'm a healthcare lecturer at Aberystwyth University, and my background is in paediatric nursing, and that's intensive care and palliative care. But we only actually started as lecturers in June this year, and our manager, Amanda Jones, approached the group and said, look, we really need to do something with this gardening project. We started it with the first year nursing students, and we need to really rock and roll with it. So we said, yeah, we'll do it. And that's where it all started. So that's what we're doing, and that's what we're here to tell you all about. So the content of this discussion today is as follows. So it's about the RHCW and their involvement, the green gathering site, what we would like to achieve with this project, the collaboration that we've undertaken so far, Keep Wales Tidy and their involvement, and the benefits of social prescribing, which has been touched upon several times already today, and also a chance for you to ask some questions at the end. So if we look at, we just thought it'd be a nice picture. So in 2021, Aberystwyth University was awarded monies to support the development of a gardening project and wellbeing walks, which were to involve student nurses. In collaboration with Rural Health and Care Wales, wellbeing walks were identified, and a space at the back of the Healthcare Education Centre, also known as HEC, was to be used to create a wellbeing space. Aberystwyth University has highlighted two areas which do need to be developed: the Healthcare Education Centre gardening project, as it was known then, and the green space on main campus, where all students can hopefully visit to reflect, learn, decompress, meet friends, practice mindfulness, perhaps, or indeed get their hands dirty. We took the lead on this project when we commenced in the post in June, and over time our ideas were generated. It came from literally writing a spider diagram on our journey from Pembrokeshire up to Aberystwyth University and going, oh yes, we could do this, we could do that. And we ended up with two sides of a spider diagram. So over the next 12 months, we aim to create a student-led working group. We will be inviting service users and carers to build on the network of knowledge and understanding to develop our vision further. We plan to develop this area over the course of the first 3 years of study, meaning that after this period, our project hopefully can be left in the hands of future pre-registration adult and mental health nurses, to build on the understanding of green social prescribing, which we will be developing at the university. Just to give you a little bit of insight and to make it a little bit more live, you can see on this map here, this is where the green site, the green gatherings will be. So we've got our Healthcare Education Centre, and just to the back of that, it almost looks like a little bit of a shovel, doesn't it, really? Mm-hmm. Lots of wildlife are already present. It does look like our little version of Watership Down. We've got bunny rabbits everywhere, and we've got squirrels, we've got various bird life. It's beautiful. It really does enable us to switch off. It will be an ideal spot in the summer months, particularly where we can all keep an eye on the area and literally, hopefully, watch it flourish and grow if we do things right, which with the wonderful support we've had so far from Keep Wales Tidy, hopefully shouldn't be an issue. Ideas for an alternative outdoor teaching classroom has been mentioned quite a few times.
Carry on, Tor.
Okay. What a wonderful space it will be to learn, and literally blue sky think. As well as having the physical benefits of being outdoors, not to mention we're all a little bit deficient in vitamin D, our mental health and increased feelings of well-being, both as staff and as students, and hopefully our networks along with the local public. Sharing responsibility of such a project and welcoming students' ideas on how best this green space can be designed leaves us feeling really, really excited. Allowing them to really understand the role that the networking and searching for local health needs plays in the wider public health agenda. and come up with different ideas and enable them to get really stuck in and truly feel and see the benefits of social prescribing, and bringing together so many diverse people from across the location, such as Aberystwyth, truly fulfills the notion of that social prescribing and the importance. And I'll pass you along to my colleague.
Thank you, Nicole. So in looking at the area, we completed some research, the area where we wanted to initiate this project. We looked at the WIMD, which is the Welsh Index of Multiple Deprivation. And in that, we were able to find that in Aberystwyth, access to services, as we've already talked today, healthcare services is limited, and also access to green space. So that just really enthused us more to continue with this project and hopefully invite lots of different people to come. So we heard earlier on today from Alunid Morgan. She was talking about the National Framework for Social Prescribing, which has been created by Welsh Government in August of this year. And just to re-quote what Alunid had actually said, that social prescribing is an umbrella term that describes a person-centred approach to linking people to community-based non-clinical support. It is a way of connecting people, whatever their age or background, with their community to better manage their health and well-being. This really fits with the ethos of what we are trying to achieve here. So what we would like to achieve, these are the ideas that we have. We want our space to be, shall I continue?
Yeah, carry on.
We want our space to be a sustainable and environmentally friendly space that is fully inclusive, with all the reasonable adjustments made so that those that are more vulnerable in our community can access green gatherings. Sustainable, environmentally friendly are also part of the national agenda in Wales to be a healthier Wales and to be a greener place. We've invited members of the local community that are vulnerable and have no access to a green space, and I'll tell you more about that in a minute. We wish for this space to reflect the diverse culture in Aberystwyth and celebrate our differences, bringing together isolated individuals and communities and promote a sense of community in green gatherings. Green gatherings is very much in its infancy, and we wish to collaborate with all interested to co-produce all ideas on how this space can be used, for whom and for what. Our students are already involved, and this experience of collaboration with the more vulnerable members of our community will enhance their learning experience and ensure that they always retain a person-centred approach in their future careers in nursing. All right, okay. So we've already been involved in some collaboration with the Wallich, which is the homeless charity in Aberystwyth. They are very keen to be involved with us. We've been involved with DDAS. They have members of this service that wish to participate. And we've also been in discussions with the domestic abuse service, Michelle, who's very keen to get people involved in this. And from today, an event like this, networking, we've met Ben and Jack, who have agreed to also participate. And there was somebody that approached us earlier called Luke from Age Cymru. So we've already made more connections again today, but we are in talks with local community mental health teams. I've contacted a local group that support people with a learning disability. We are looking to support the older adults, specialist CAMs, and be in touch with the West Wales Action for Mental Health and Ceredigion County Council. So next slide. That one there. So in the course of this work, I don't know if anybody has experienced this, but some things just happen and we can't explain why. Nicole and I were looking through social media and we came across a post from Keep Wales Tidy stating that you can apply for free grants. Now, we like the word free because, you know, it doesn't cost us anything. So we applied immediately. Well, we made contact with them first of all, and we've been offered, well, we were quite successful. This one, which one? That one, yeah. We were successful in gaining an orchard package. So this is very much at the start of how we're going to build this with an orchard. And you can see the list of everything that we are being given for free. We're going to be completing another package now for a grow your own. So I just want to share with you that we have at the end of this presentation put the the QR code for anybody else that would like to apply to Keep Wales Tidy for one of these packages. This all fits in with the Welsh Government agenda and the network. So in looking at the benefits of social prescribing, we know that gardening has a long and connected history to science and medicine. For centuries, gardens have been a source not only of food on the table, but also remedies to treat common ailments. Some of these, such as St. John's wort for depression and willow for headaches, have been embraced by modern science. But what about the benefits of gardens and gardening themselves? It is increasingly acknowledged that gardens and green spaces are associated with better physical, social and mental health. And the British physician Sir Muir Gray famously said that everyone needs a natural health service as well as a national health service. And the NHS since January 2019 officially included social prescribing in its long-term plan. So we have a 5-year plan that we are still working on, but we hope at some point that maybe our green gatherings might be something that the GP networks locally could prescribe to the people that attend. And we've heard about those stats earlier on this morning about how many people would benefit from this. So a King's Fund report on the health benefits of gardening were found to be broad and diverse, with research studies showing significant reductions in depression and anxiety and improved social functioning. And we know that in 2017, the World Health Organization published their report, Urban Green Space Interventions and Health. So this is what has initiated to the Welsh Government providing their strategy going forward. So I'd like to show you the QR code. So thank you very much. If anybody for their own project is looking to apply, would like a free garden package, please, get in touch with Keep Wales Tidy. They're particularly interested in creating more green spaces. So I'd like to say thank you very much on behalf of Nicole and myself. And are there any questions? No time? Thank you.
I'll get into trouble for this, but never mind. I can deal with trouble. Is there one question that anybody would like to ask? No, there is one comment. There is one comment in line that talks about the National Garden Scheme.
Okay.
And where you are with that.
Thank you very much.
Okay, thank you both very much indeed. Thank you for that. Matt, over to you. Thank you very much indeed. Matt is going to talk about queering compassionate care. Over to you, Matt.
There we go. Thank you so much. Good afternoon, everyone. I've purposefully used the word queer because it always puts us a bit ill at ease. And it's like, oh my goodness, has he actually used that word? But by background, I am a queer theorist and a queer academic, so I'm quite comfortable using the word. But rural communities are notoriously ill-equipped to deal with the health and social care needs of the LGBTQ+ community. Historically, queer folk such as myself would either migrate away from rural areas to find like-minded people in the metropolis of perhaps Cardiff or Manchester or London. And as a result, there's an increased underrepresentation of queer identity in rural communities. But most significantly, for those LGBTQ+ people who cannot leave rural environments, they are presented not just an underrepresentation of their marginalised community, but also an inability from healthcare professionals and our focus in Aberystwyth University's registered nurses to actually deal with and care for people who self-identify as queer. So I welcomed Lynyd Morgan's statement this morning of adopting creative and dynamic ways of approaching healthcare. So in my 10 minutes, I just want to run you through what we're doing at Aberystwyth University to tackle head-on queer disparities in nurse education programmes. I've unashamedly popped up. Oh, it's not. Oh, there we are. Ugly mug there. But just to let you know, my research interests, I'm an ITU trained nurse by background and neuroprotective measures in intensive care. But my research interests are around queer visibility and inclusivity in healthcare and also queer end of life. So I've started a campaign, #QueerPeopleDie2, because research shows that registered nurses are ill-equipped at providing efficient end of life care for our LGBTQ+ friends. So I'm LGBTQ+ lead for Aberystwyth University's Healthcare Education Department, and part of that role makes allows me to ensure that all of our nursing curricula is gender inclusive in practice, and also that it responds to both the Welsh Government LGBTQ+ Action Plan for Wales and also the NHS long-term strategy. Thank you. So a bit of stats. We all love stats as academic and researchers, but I think this slide goes to prove that we've got quite a bit to go. And the research really does speak for itself. So unless you're part of the LGBTQ+ community, either as an ally or an active member of it, you may be unfamiliar with LGBTQ+ health inequalities and barriers to accessing health and social care services if you do identify as LGBTQ+ or queer. Of particular note, and while we're on this slide, is that 13% of registered nurses feel able to meet the needs of queer patients and service users, which I think is quite low when we think about how many people we care for. And then perhaps linked to this, which is quite worrying, is nearly 60% of healthcare professionals do not believe that someone's sexual orientation and or their gender identity is relevant to their health needs. So that's quite concerning for me as both an academic and a practicing nurse. Another worthy point of note is that of those registered nurses who do not feel able to meet the needs of queer patients, their confidence plummets quite significantly when having to provide palliative and end-of-life care to our queer service users. It's not all doom and gloom though, and I'm very pleased and I do welcome the recommendations and strategies of the Welsh Government and its recent publication of the LGBTQ Action Plan for Wales. That said then, is awareness training enough? And does awareness training equate to competence and cultural competence in practice? And I would argue that it does not. That's not to say that awareness training doesn't have its place. And I'll agree with those who say that some form of training is better than none at all. Absolutely, and I couldn't agree more. However, if we take time to digest the statistics from the previous slide, there's a global recognition that registered nurses tend not to be able to practice cultural competence and congruence in their practice. That said then, if we link this to rural healthcare education service provision and how we are training our rural nurses at Aberystwyth University, I think we do need to redress the nurse education service provision and education programmes in Wales. Is there a welcome in the hillsides? So in LGBTQ+ rural identities, the research has shown that unfortunately there's not. So there's international recognition, and we've heard about the research being carried out in rural Canada this morning, that rural LGBTQ+ identity and the disengagement of healthcare service provision is an academically neglected area of research. And I think this really does strengthen my argument that we have to approach nurse education with a queer slant and at a slightly different edge. Of note on the above slides is that rural areas often create greater visibility for LGBTQ+ people. And you might think that that's a good thing, but it's not. What it's actually saying is, for those who haven't been able to access perhaps a queer utopia in a metropolis, you stand out more in a rural community. And as a result, you're more targeted and marginalised. So if we have a look then at what we offer at Aberystwyth University, LGBTQ+ patients statistically less likely to access non-emergency health and social care. And this indeed for me as an academic is worrying, considering that the research notes that queer people living in rural versus urban populations are more likely to have issues with substance misuse. They partake in increased sexual risk-taking. There's lower levels of HIV testing due to challenges of access. There's lower knowledge levels of HIV, and there's increased mental health concerns. So all of this together creates quite a worrying brewing pot of concerns that our future registrants and our current student nurses at Aberystwyth have to adapt to. So I'll just run very quickly through what I'm doing at Aberystwyth University. In year one, our student nurses are introduced to what LGBTQ+ means, as well as inclusivity and visibility training in healthcare. Importantly, this is indicative curricular content. Our student nurses have to complete this training as it's mandatory for the programme. Year two, then, I look a bit more at law and ethics underpinning the registered nurses practice with a slightly queer focus. Are we providing legally and ethical care? And then in year three, we consolidate this in readiness for when our students will cross the threshold from student to registered nurse status. So experiential learning, a hands-on approach. And we aren't just providing lead lectures or what I sometimes call chalk and talk, and my students will say, oh, your math goes again. But we make the learning a hands-on approach for our students. So examples of this include LGBTQ plus service users' contributions to curriculum content and they influence its direction. Queer service users coming in to speak to our student nurses about what it's like to be queer and receive culturally incongruent and incompetent care. And this is also visible across all years of the programme. In year 1, we also have a maternity day where we look at transgender pregnancy and transgender birth, and when a transgender man, for example, will give birth. And we've got specialist midwives who work in Bronglais Hospital coming into the nurse education programme to talk to our student nurses about how they deliver that transgender pregnancy care. And then we also have transgender people living with dementia, which is a current area of focus for my research. As if you're transgender and live with dementia, research has shown that you regress back to the assigned gender at birth. So how do we competently care for you if you have dementia and if you are a transgender person? We also have a virtual family in Aberystwyth University, and this is taught alongside our students' instruction. So as the students progress through their course, the family gets increasingly unwell. But of particular note is Jack in this virtual family. Jack Jenkins is currently gender fluid at school, and he has issues accessing queer sexual health service provisions. As Jack grows and develops, so too is queer identity, and our student nurses are required to then adapt to Jack's needs and respond culturally with it. Some case studies and debates that we've had in university that really challenge the ethical and moral dilemmas of our student nurses face in practice. Things such as a transgender man is admitted to a hospital with gynecological concerns. So we use making every contact count approaches with them, and how do our student nurses engage with that transgender man. Similarly, transgender women with prostate concerns. So how do we deal with a transgender woman who has prostate issues? And then we have gender neutral, gender fluid and gender non-binary patients versus the gender binary construct of healthcare. If you have a patient admitted to your ward who doesn't have a gender, in what bay do we pop that patient, or in what side room do we nurse them? So we're really providing that wraparound queer care for our patients. Another example is, for example, transgender men who typically bind at home may not be able to bind in when they're admitted into hospital. So how do we challenge our own preconceptions of what it means to be queer? And I just want to finish with some student feedback we've had so far. And the top one is really emotive for me. The student nurse approached me and said, thank you, I finally feel that I belong and that I deserve to be a proud queer nurse. So this is one of our student nurses who's currently gender neutral. Another one is, sure, I thought I treated everyone the same. Now I appreciate that that's not necessarily a good thing. We can't provide equal care. We can provide equitable care, but we can't treat everyone the same. Another comment was, I'm lucky that I've never had to worry about accessing health services. I'm definitely more LGBTQ plus savvy now. And then the last one is, having expert teaching from queer people definitely makes it all more relatable. So it's just a little flavour for you today in 10 minutes of what we are doing at Aberystwyth to provide that queer focus on nurse education programme. So thank you very much. I talk rather quickly. And now I'll open the floor if you've got any questions. Thank you.
Thank you, Matt, for what is a very eye-opening discussion. Thank you for that. And another note for us all, when we're appointing people and we're giving people jobs, we want to keep people. So our welcome in the hillside is really important. And that's really key. And that's another key note from you today. We've got time for one question, even though he does talk very quickly and has made up the time. Have we got a microphone available? Magic, thanks.
Really interesting, very eye-opening. I was just wondering if there was any conversation or thought to roll this out to other universities, other healthcare professionals, and the health boards as well.
Yeah, and that is the hope. So I used to Before I joined Aberystwyth as a lecturer, I was a visiting lecturer at Swansea, where I provided micro training, and I've also provided health board specific lunchtime bites, where staff can come along for like a 20-minute wraparound programme of what we can achieve. I am keen to collaborate with people if they would like to roll out a network, because I do think that this is a no-brainer really. In order to be culturally competent and provide congruent care, our future registrants have to be on side with this. So I would like to. So if anyone in the room does want to collaborate with me, do please email me and reach out and we'll take it further. Thank you.
Thank you, Matt. Thanks so much for that. Thank you. Okay, I'm going to move us on now to Fran Loud and Amy Kordiak, community catalysts in Gwynedd, particularly Wrexham, I think. So over to you guys. Check for a minute. Doing a random wheel check.
Is it online? Yeah. Okay, so now good afternoon. We're here from Community Catalysts and our presentation is around recruitment and retention of health and care professionals in rural areas. So I'm Fran and I'm the Community Catalyst in Gwynedd, and this is Amy and she's the Community Catalyst in Wrexham. The presentation is bilingual and there'll be a chance to ask questions at the end, and I'll hopefully try and answer some in Welsh if anyone's got any.
So just first of all, I just wondered if anybody's heard of us, Community Catalyst, if you could just put your hand up if you have. So just a couple of people. So we're a well-kept secret, but hopefully you'll find out a bit more now. So we are a small team of people. I don't think this is quite working. Who believe in the power of community, and we're all around people-led social care. And we help local people to help other local people. So that's the main emphasis of the work we do. We don't think that one size fits all, and everything we do has a hyper-local focus, which is what we've heard a lot about today. We want people to have choice and control in their community and over the care that they receive, and we want them to retain their independence for as long as possible and get help in their home. So we're across the UK, and we have got several different programmes running across Wales, which Fran's going to tell you more about. But the micro part is that we support people to set up small enterprises with less than 8 people. So generally speaking, it's sole traders that we work with. We can't do next slide, so the next slide will be up there now. Okay, so the rural challenge, I won't talk too much about this because we've already covered it, I think, quite a lot today, but obviously lack of services out in the community, and people are reliant on commission care quite often, and that may not be available in rural locations. We have cross-boundary challenges, particularly in Wrexham as well. There's social isolation as well, and that's not helped by poor public transport. So people are less likely to go out and interact. And then they also have digital exclusion as well. So they might have poor Wi-Fi, so they can't connect to things like we've got on today. So that's obviously another issue. Funding challenges, so less money generally around. And the thing that we want to concentrate on talking about today is poorly paid jobs in the sector, really hard to recruit into the sector. So this is why we think it's really important to keep a hyper-local focus. And obviously the same things that they're not necessarily a rural issue, but carers working for long hours, poorly paid roles. So we try and change that a little bit. I'm going to talk to you about the elevated rates of pay that we've negotiated with councils as well.
So what do? We support people to set up micro enterprises that provide care or support to older people or people with disabilities. As Amy's mentioned, we've got several different projects at the moment. So they're all over the UK, but in Wales, we've got a project in Wrexham, Gwynedd, Powys, Rhondda and Taff and Cardiff. We ensure that the enterprises that set up are safe, legal, sustainable, and most importantly, that they operate in a person-centred way. We work in partnership directed by local need. And we also have a directory called Small Good Stuff, which people can search if they're looking for care or support and in specific areas. And it also helps the enterprises to advertise themselves and the services that they offer. So how we do it? We work in partnership with councils. This is crucial. They'll usually let us know where we need to focus our efforts. So it could be around home care, or it could be setting up groups in the community. We aim to recruit in rural areas where the job opportunities are low and there's a lot of demand. And as Amy said, the focus is hyper-local. In Wrexham, 30% of the enterprises that set up were already working in care, but 30% were unemployed. We try to promote the service that we offer to people that might have had a bad experience in care and may want to move away from the sector, and just to show them that positive outcomes that can be achieved and hopefully retain them. We offer a free development programme, and there's also a small grant available in most areas to help people with the setup costs. The programme's tailored to an individual's needs. We can meet with people one-on-one or in groups. And we take small steps with everybody, so it's less scary. We help the enterprises shape their service that they want to offer and let them know what good care looks like. And we can signpost them to specific training like tax and things like that. And then through my project in Gwynedd, the council offer a lot of training packages. So most of the training that's available to the carers working for the council, the micro enterprises can access as well. Yeah, and we help the people to promote and launch their enterprises, and we're on hand then going forward if anybody's got any issues.
Okay, so the types of care and support on offer. So the beauty of it really is that we work with the council around, so the enterprises are paid through direct payments generally, or sometimes private payments. So that means that people should have choice and control over what kind of care and support they need. And it obviously will relate to their care plan, but the types of things that they have on offer. So in Wrexham, which is sort of our flagship programme, we've got 84 enterprises up and running. We've been running for 3 years. And of those, 55 of them offer home care. But the other services are things like dog walking, transportation, food, gardening services. There's lots of companionship and befriending calls. We also have a community farm. It might be chiropody. So the beauty of it is once we've set somebody up as a sole trader or as a small enterprise, they can diversify to the needs of the population. So if that community is saying, you know, there's more of a need for companionship, then we can say to them, okay, maybe we could train you now in a slightly different way to meet that need. And as Fran said, we get lots of free e-learning from the council as well in Wrexham, where I'm based anyway. So yeah, so it's a whole kind of plethora of different activities that could be available to that person.
So what are some of the benefits of using a community micro enterprise? It gives the person receiving the care choice and control. It can bolster the local economy. And we ensure that the micro enterprises receive a fair rate of pay, and they're flexible with the services that they offer as well. We promote social cohesion and also rural options where there's a lack of agencies. We hopefully retain local talent and keep people in care and support. Emphasis around personalised service and being responsive and adaptive to local need. And the micro enterprises, as Amy said, they can be really flexible and offer, you know, what's needed in the area.
A bit of backwards and forwards here. So there's challenges, obviously, though, obviously, as well as the benefits. So there could be financial constraints. So, you know, smaller rural budgets, it can cost you a little bit more sometimes if you're working with somebody that you're paying privately to. They are restricted to hyper-local areas because of petrol and mileage and having to claim that back through tax. So sometimes, you know, we do tell people to keep sort of within a 10-mile radius of their home so that they don't have to have that on cost. There's also, so once you've recruited that person or you've got that person in to work with you, then if that carer is sick or if that person giving the support is sick, there is no replacement. So we talk to the enterprise about being really upfront and honest about that from the outset and making sure that there are family members and that they're responsible in how they set up the care. There's also a lack of awareness around direct payments. So we're working really hard with council departments, and luckily where I work in Wrexham, there's a really good awareness. But trying to promote that to people. So to say to people, you have got choice, you can have commission care, you can have a PA, you can also have a direct payment, so long as they've got capacity to make that decision and they can choose and control their care. So we're trying to just raise awareness around that, but quite often people won't put it forward as a viable option because they just don't really understand how to set up a direct payment or how it works. So as I said, the customer must have capacity around making their own decisions. We can't also, because they're not registered, so they're outside of CIW registration, and they're allowed to do that because they're very small enterprises. It means that they can't deliver any delegated healthcare tasks, and they can be restricted on what they can do. For example, they can't give medication. So if somebody does need specialist support, they are limited in what they can do, but we make sure that they're very aware of that. And then that also unfortunately can prohibit their growth. So if they want to take staff on, there are some regulations around how many staff they can take on and how many people they can offer home care to. Oh yeah, so I just wanted to highlight an example then of when this has worked really well. So you may or may not be aware of the Glencairn Valley. I wouldn't, if you don't know where it is, that's fair enough. It's sort of between Wrexham and Llangollen. It's really remote, very rural area. And what happened was, after we'd set up the Community Micro Enterprise Programme in Wrexham, we were approached by the council, this was during lockdown, saying that one of the agencies there had closed. And people were going to lose their jobs. People in the area were going to have to be moved into care homes because there was no care available in the area. What could we do to sort it out? So they said, could you go and have discussions in the community and see if any of these workers would like to be self-employed? So obviously that's really scary for people. And that's one of the challenges that we have to overcome is, to move from employed to self-employed is quite scary because it's wondering, will you get those customers? Will you get that work? So what we did was we talked to people, and actually the council agreed an elevated rate of pay, which I spoke about before. So they said if people will work for themselves and help us here, we'll give them £16.73 an hour. And these people used to getting about £12 an hour. So it did work out. They were financially better off to do it. So we talked them, we said, we'll take the sting out of it, we'll make it easy. So we then, within 3 or 4 weeks, we managed to set up 10 micro enterprises in Wrexham. And what that then meant was that those people that would have been moved into care homes, they were able to stay in their own homes, they were able to keep their carers, and the people didn't lose their jobs. So it was really a really fantastic outcome for Wrexham, and they're still up and running now. And the carers, 100% of them that we work with have said we wouldn't look back, we would not swap back. And that's not to say there's not a need for agencies. Of course there is, and we're not in competition with agencies. But I think it really suits a lot of people where particularly they've been restricted in terms of their flexibility, or, they've been a little bit disheartened with the pay. Once they work for themselves, we've had really positive results.
Okay, so just to summarise really how community micro enterprises are trying to provide solutions to the rural challenges. So we ensure that the enterprises receive a fair rate of pay and understand the importance of offering flexible service. When we're working with the enterprises, we can nurture their confidence and skills. Another positive effect of this is that by showing the positive outcomes that can be achieved, hopefully we can retain people that might have been thinking about leaving the sector. The enterprises work hyperlocal, and this is vitally important to help people live in rural areas, as Amy's case study just highlighted. When someone uses an enterprise, they can develop a relationship with the person supporting them, and they know that they'll have continuity of care and choice and control of their care. So that's the main positives, really. So we'd just like to ask if anybody's got any questions just to finish up.
Dancing on the platform. Thank you very much for that. Insightful stuff, really, isn't it? I mean, that particular case study is a really good example of how to retain people and how to keep people out there working on where they love to work. Really good example. Any questions from anyone in the room? Anybody want to set up a micro enterprise? Please see these girls on the way out. Okay, thank you both very much indeed. Thank you. And thank you to all the speakers, and my sincerest apologies so far for the IT glitches, particularly those online. I do apologise for that. We are obviously working as we speak on that. So we're now going to go to Dr. Joseph Janes, who's a criminology lecturer in Swansea University, who's going to spike on the bike.
And applause to start, always a good way to do the day. Good afternoon, everybody. I'm Joe Janes. Like I was just introduced then, I'm a criminology lecturer at Swansea University, and today I'm going to be talking to you about the Spike on a Bike project. We've heard already about rural Canada, and I'm going to sort of drop in rural Canada again. This was born out of something called Spikes on Bikes, which was started in rural Canada about delivery of harm reduction and clean needle kits in rural parts of Canada. So yeah, today I'm going to be talking about a new project, Spike on a Bike, which is in Dyfed, in the area of Dyfed, sorry, DDAS, Dyfed Drug and Alcohol Service, where you can get clean injecting equipment and other harm reduction services delivered straight to your door, fast and free. This project and what I'm talking to you about today is very much the research that's gone on behind the scenes in a partnership approach between the Health Board, DDAS and Swansea University. Thank you. Presentation structure. So today I'm going to talk about an overview of what Spike on a Bike is and does, key findings of the research so far, some key points in closing remarks, and we'll have some opportunities for questions then. DDAS we've heard from today as well as Canada, and we're talking about Dyfed Drug and Alcohol Service, which is an integrated Barod-led consortium service supported by Kaleidoscope and G4S. DDAS is the first point of contact for any adult over the age of 18 with a drug and alcohol problem in Dyfed, covering the counties of Carmarthenshire, Pembrokeshire and Ceredigion, and supporting service users who have drug and or alcohol problems. Services that are offered within this and from Spike on a Bike within itself around needle exchanges, dry blood spot testing, open access assessments, group and coffee mornings, and smart recovery, as much more. Harm reduction is a key public health approach, aiming to improve the safety of drug injecting practices, especially in Wales. Among a range of interventions, it includes needle and syringe exchanges, which have numerous benefits, not least reducing the risk of bloodborne viruses and transmission, such as hepatitis. During the COVID pandemic, most notably during the intervals of lockdown, there was a reduction in the uptake of harm reduction services in the areas of Carmarthenshire, Ceredigion, Pembrokeshire and Swansea. And this is where DDAS observed a decline in service use activity. I've got another slide coming up soon, which gives you some of those statistics. And the initiative project to try and solve that gap and deal with that harm was Spike on a Bike, providing harm reduction services fast and free to the door, ordered via the internet. Thank you. So some stats you can see here in terms of reduction, the number of transactions pre and during COVID at 39%, number of new registrations was down by 34%, and the number of items dispensed, sorry, was down by 41%. So some of the impacts of coronavirus on harm reduction were significant, as you can see here. Decreased uptake during the pandemic, linking to, and we've heard about this a lot today, around hidden communities and hidden voices, and how we can sort of illuminate those voices. The stigma of accessing fixed services, especially in the political climate. You know, if anyone's been living under a rock the last couple of weeks, what's been said politically around homelessness, the same goes when we're talking about those who use substances, okay? There needed to be an amendment of service delivery models, and we need to evolve and emerge in a new climate of service delivery, yeah? And that's what's so important about hearing from people's voices with lived experiences, to really understand that. And it's important from a public health perspective. The goal here is to increase service user engagement, reduce harm and risk, and especially overdose death. So what is available? Naloxone dispensing, overdose prevention advice, bloodborne virus testing on the door, collection of sharps, just to name a few. Next slide, if possible, thank you. So As I noted at the start of this presentation, this has very much been born out of a partnership approach. Initial links between the health board and DDAS, and then discussions with myself and Swansea University, beginning in a research steering group which meets monthly to discuss how we can evolve and work together as a partnership. And this evaluation was embedded alongside service delivery. As I said, creation of a steering group and the initiation of an evaluation, which found, and we're going to go into some of the findings in a bit, but it found that it is a much needed service, something that does really address some of those root causes and some of those hidden populations that we discuss. Thank you. So, as I noted earlier, spikes on bikes. And there is a growing body of literature examining people's fear of leaving their homes during COVID-19 and the associated psychological effects caused by isolation during the pandemic. Evidence suggests this was especially so in relation to unwillingness to or inability to attend healthcare settings, as I talked about in the previous slide, around stigma and addressing things like stigma. So this is, as we know, a health barrier, and it paramount to achieving a engaged public health service is something that we really need to take note of. Such a dilemma is amplified in the case of those having difficulty in accessing things like public transport, for example, the availability of which was also detached during the pandemic. We've got some quotes here. I became lost in thought. This is from Sian Roberts, Barrod's service manager. I became lost in thought, contemplating ways in which we could solve this problem, something a bit out of the box. This has obviously seeped deep into the subconscious that night. I dreamt of riding motorbikes full of 1 ml completed syringes and Stericups across the hills and valleys of West Wales, bringing a whole new meaning to the Heart of Wales line. Okay, and this is something that was born out of that. If you could jump to the next slide, thank you very much. So some key research findings here I want to sort of highlight for you today. Access to rural areas was strong throughout the Spike on a Bike programme. Difficult to reach access groups was strong, measured by a large uptake of harm reduction equipment, quick and efficient delivery and good communication with service users. And something I noted as well as a researcher was the building of rapport between service users and practitioners themselves. Wide demographic access, there was a high female uptake, 38% of orders, and a wide range of ages, under 20 to 50 plus, using the service. So in terms of being an encompassing service, this is something that Spike on a Bike managed to achieve. The research sought to examine the implementation and delivery of the programme and highlight areas of good practice and potential areas for improvement. Several methods were utilised, including semi-structured interviews, questionnaires, surveys, as well as that, participant observation, sitting in on coffee mornings and speaking to the people who matter most, those people who require the services. Thank you very much. So some service user impact, these are some nice quotes. It was recommended that steps be taken to implement Spike on a Bike in other rural areas, and these are some of the reasons why. I would never have engaged with services if it was not for Spike on a Bike. Where I live and how I live my life made this nearly impossible. If the rider had not engaged with me several times, I wouldn't have come into the service. Okay, that's from a service user, Mr. Thomas. And when we think about how important building rapport and trust is between service users and practitioners, this sort of doubles down on that. I used to go into the pharmacy for my friend as they were too scared. Stigma of getting pins and kits. And ironically, when I started using, it was harder to get hold of needles and kits than it was to get hold of heroin. Yeah? And we think about access in communities, especially rurally, this is something we need to consider. I was sitting in my GP when I saw a poster for Spike on a Bike. At first, did not believe it was a real service. I scanned the QR code, did some searches, and made my order that first evening. And this is something that's reflected on by quite a lot of service users within Spike on a Bike. Is it too good to be true? Does this service work? Will the police just turn up at my door and arrest me? And trying to get that across and building that rapport was really, really interesting and something that practitioners strive to do. So final thoughts here, there's some main points. Importance of a service delivery model, especially one that uses service users' voices and the voices of practitioners, okay? Sometimes we get lost in this sort of world of only listening to elitists. We need to listen to people who are on the coalface. Valuable from a public health perspective, There's further work needed, including research around this to see how we can test this in other areas and bridge those gaps, and opportunities for wider rollouts. Like I said, service users' disbelief at this level and type of provision that was available needs to be addressed. Summed up by service users who said it was too good to be true. Such a perspective was repeated by many other users, and paradoxically, in some ways, is a barrier to that sort of access. So thank you very much. Any questions? Yes.
Thanks, Joseph. Thanks for that. Again, really good example of innovation and thinking outside the box, which is what we've been listening about in the last session, really. Over to any questions in the room to start with. Roving microphone would be good. To Mr. Evershed.
Thanks, it's great. The bike delivery people are obviously a crucial part of this service. Are they employees and are they trained in any way, or do they just, you know, is it like blood bikes or is it different?
Well, no, they're practitioners. So they are practitioners. And when DDAS now are trying to hire new practitioners, one of the things they focus on is an ability to or want to ride a motorcycle. And by joining, they will, and has happened, they've had their license as in paid for bike license and the training courses that come with it. So yeah, it's sort of a unique selling point as well, I think. So if anyone else is interested, get in touch.
Okay, anybody got a bike that's looking for a job, online or otherwise, you know the man to contact. There's a question over there. Have I got any questions online just as well, so I know where I'm going? Thank you. Thank you.
Kits using the same sort of style because it's much more common in Scotland.
Yeah, and naloxone is one of the things that is delivered by Spike on a Bike, and DDAS do offer training and deliver through that, working with different agencies of support, including the police and healthcare practitioners. So yeah, most definitely really important.
Great, thank you. Thanks for that. Any other questions in the room before I move it on? No, any questions online? No, okay. Thank you to all the speakers. Thank you, Joseph. Thank you to all the speakers in that session. It's not easy cramming in that time. So well done, everybody. Thank you. And show some really good examples of challenging the norm. And, you know, some good examples all day today so far, isn't there, in challenging the norm and getting out of that normal thinking. Thank you for that. Now, the next bit is pretty complicated and it's up to you guys, this next bit, right? Because we've got a number of breakout sessions happening and we will not touch base in between them. So you're going to now go to your next breakout session, which will be either in the pavilion over the drive or in here. And then we're going to swap at 2:30 to our next breakout session. And then you're going to be back in here promptly. I'm going to repeat that word, promptly for 3 o'clock. My teams who are out there in the pavilion, promptly for 3 o'clock, so that we can start the plenary session back again after that. So we're going to move now to our breakout sessions in the pavilion or in here. If we could do that as quickly as possible, that would be great. Just to be really clear, I know it's clear on the programme, but just to be really clear again, the ground floor session now in the pavilion has been cancelled, so it isn't available. So there'll be other sessions that you can. I believe the links have been sent out for the online team, so there should be an ability to be able to check in online. Thank you. If we could do that as quickly as possible, that's great. Just to move on or stay, because we need to really keep going on the time. Really sorry, guys. Apologies for pressurizing everybody. Sit and stay or go and move, one or the other. Thank you all. Mr. Evershed is taking the really the run, so to speak. Good. We won't wait for you to get back, Jack. Okay, so thank you everybody, and thanks for being so efficient on that. I am going to introduce you now to Ray Workman, who is the Group Customer Success Director for this session, and this is how is telemedicine bridging the gap? And oh, hello. It does. So over to you, Ray. Thank you.
Hello everyone, good afternoon. Welcome to this session. My co-presenter Alistair is here right on cue, right on time, so we'll just give him a second. But welcome to the session where we'll be discussing how telemedicine is bridging the gap in rural healthcare across Wales. So as mentioned, my name is Ray Workman. I'm Group Customer Success Director at Consultant Connect. And Consultant Connect are a telemedicine provider who facilitate remote advice and guidance across Wales. We've been doing that since 2020. As they say, I'm joined by Alistair Rose this afternoon, who is National Clinical Lead for Primary Care and Community Services and National Clinical Lead for Health and Care Pathways. Apologies, I'll just skip us on, missed a slide. So in terms of oh, sure. Yeah, no worries. So the first thing to kind of caveat is that we facilitate conversations between all health and social care professionals. I think sometimes with our name, Consultant Connect, it's sometimes a misconception that we are consultants only who are taking these calls, and that's not the case at all. So we facilitate these conversations between primary care, secondary care, community, tertiary, mental health, and so on. And you'll also see in the diagram, and when it comes up on the screen, that we also support the Welsh Ambulance Service Trust as well. And that's both in terms of them placing calls into hospitals, but also into GP practices via the bypass numbers. So a dedicated route for them to speak to primary care as well. And Alistair will share an example of that in due course. And as cheesy as it sounds, if you could see the diagram or if it popped up momentarily before, you'll see that the patient is really at the centre of all of these calls and all of what we do across Wales. So in terms of, skip through, in terms of some key figures. So we're really delighted that we were awarded a contract by Welsh Government recently, a 3-year contract. So as I mentioned, we've been working across Wales since 2020, but now we'll be doing so for another 3 years. So we're delighted that we can continue to support patients and healthcare professionals across Wales. There are already over 700 lines on Consultant Connect for across Wales. So that's, as we were saying earlier, primary care, secondary care lines, community lines, and so on. And last year, in 2020, over 18,000 unnecessary hospital visits were avoided by having those conversations with specialists and seeing what the right care was for the patient. And finally, in October, so just last month, over 10,000 calls across Wales were placed by the platform. So a huge volume of calls being placed, which is brilliant to see. So how does remote advice and guidance actually work? Well, there are 2 main ways. So there's telephone and there's also messages as well. So let's start with telephone. A health and social care professional can download our free app. They register selecting their relevant organisation. So that may be their GP practice or their hospital or their community team, whatever it may be. And once they've registered, they're then given access to the relevant Health Board and Pan Wales advice and guidance lines. They simply tap on a specialty or a team that they wish to speak to. And here's the really clever bit. Our system routes the call through to a rota of potentially available specialists. So if the first specialist on the rota can't answer, they simply don't. It may be because they're with the patient. The call then rolls on to the next specialist on the rota, and so on and so forth. And that's how we get the increased connection rate and increased connection speed when specialist advice and guidance is required. So just for a bit of context there, across Wales, the average connection speed for telephone calls is just 25 seconds. So if you compare that to a call that's going via a switchboard, or perhaps, you know, someone doesn't know who to call for that advice and guidance, it's much prompter. Messages work similarly, apart from what we do is we work with teams who are requiring the information to work with them on really detailed pro formas to ensure that they're capturing all of the information that they need up front to then be able to provide detailed advice and guidance. So it prevents the toing and froing when there's a need to get prompt patient care. There's also the ability to take and attach IG secure and GDPR compliant patient photos via the app. So using your own phone, but in an IG secure and GDPR compliant way, attach that to the message and send that on for advice and guidance. So as you can imagine, really useful for things like dermatology. And again, this is then sent on to a group or an individual clinician who responds and provides the detailed advice and guidance. So what are the key benefits of remote advice and guidance? As we saw on the last slide, that rapid connection to specialist advice and guidance to ensure best patient care. There's also the opportunity to ensure that treatment plans are initiated immediately if that's appropriate. It absolutely helps with identifying patients who do need to be referred or admitted to hospital, but it also identifies those who don't need to be referred or admitted, and therefore preventing unnecessary referrals. And with this, the impact is also with the patient as well, that saving of time for them commuting to the hospital, the costs that they may incur for that commuting to the hospital unnecessarily as well. And finally, the environmental impact that has as well, especially when we're talking with regards to rural Wales. And we're going to share some specific examples regarding that in due course. So how is advice and guidance working in practice across Wales? I'm now going to hand over to Alistair, who's going to take us through a few examples. So over to you, Alistair.
Thanks, Ray. Thank you for inviting me along to join you. I'm delighted to share just a couple of examples of how things are actually working in Wales. I've got to declare an interest here. I am also GP as well as all those things that Ray's already described. So the first example comes from North Wales here, where they have set up and used for over a year now a dermatology advice line, but it's not based on telephone calls, it's based on photo messaging. So the GP or clinician, practice nurse maybe, healthcare support worker, takes a photograph or takes a photograph that the patient's taken and attaches it effectively to a text message, and that is delivered to volunteer consultant dermatologists at the other end electronically. And it's easy to see, just thinking things through, how quickly you can get an opinion on whether or not there's something here that I need to be worried about, there's something here that needs referral or not. And you can quickly provide reassurance, not only to the patient, but to the clinician as well. So really useful tool here. And the use of this in North Wales is growing significantly as well, with scores, if not hundreds, of photos being sent every week now to use this service. Next slide is perhaps a little bit closer to home here, and that is using the text messaging facility, but not just for text, but actually attaching a document to that text message, in which case an ECG, for example, and getting an expert opinion on what the ECG shows, rather than booking the patient in, sending, arranging transport, sending them to a hospital to have an ECG done there, or to see somebody who can look at an ECG. And you can just see the figures themselves. The way that this can streamline and transform and ensure that where you are practicing in a remote area, well away from the bells and whistles and the high tech of an inpatient or outpatient establishment, you do have the opportunity to get rapid access either there and then through a phone call or within 24 hours with some sort of text or photo messaging. It really can be transformational and so, so much better for the patient and the environment as well. Here we have just another example. It's not just about physical medicine. A really good example out in Hywel Dda with using the Consultant Connect telephone service with local mental health specialists, in this case, the perinatal mental health team. And you can see just how effective just that phone call can be at reducing the need for referring in, simply either providing reassurance over the line or giving you the definitive treatment. And clinicians amongst you will know, if you've had a good quality conversation with somebody who's local, you're going to remember that. And next time you meet the scenario, you probably don't need to call them again, because actually you know what the right thing to do, because you've got the confidence that you did it last time. So it's all part of education. It's the sort of thing that, GPs, for example, can be put in their appraisal portfolio if they're looking for evidence. This one I particularly like, and Ray has already sort of alluded to this, but it doesn't have to be specialists. It can GPs or nurses phoning specialists. It can be the other way round. Yeah, and here we have a couple of examples, but particularly WAST and paramedics in the patient's home. They're at the patient's side, and they don't really think the patient needs to be transported to the emergency department. Probably there's something that can be done out in the community. GP practices have given up their bypass numbers to Consultant Connect to support the appropriate use of those numbers to approved clinicians, such as WASP paramedics. And you can see that in October alone, across Wales, 624 calls were made by paramedics. They were answered by the practice in over 3/4 of those occasions. And you can see as a result, 69% of patients avoided being sent into ED. And in fact, the vast majority of those, 2/3 of those, the GP said, look, bring the patient down. I'll see the patient. Or some other service in the community will do it. This is massive. This is just 1 month alone, over 600 calls. It just shows that those stereotypical images of the GPs just want to fob everything off, get everybody into hospital, just isn't true. And this is another beauty of the Consultant Connect system that we've got. The data is fantastic. It's live. It's live 1 minute after the call happens. You can demonstrate it on the dashboard. There's one more slide I just want to share with you. This is down in the valleys in Swansea. And they've turned the model on its head in two ways. The local acute clinical team, so that's the community nursing staff, allied health professionals, social workers, are proactively calling care homes and saying, have you got anybody you're worried about? Anybody that you're likely to need to call us about later? Just let us know now. And they're picking up people earlier than they would if they left it to the care home staff to pick up. Also, in the second table, the care home staff have been given access to Consultant Connect. That's not the clinical care home staff, that's the social care staff being given access to the GP bypass numbers and then to the acute clinical team and the community's numbers as well. And again, using this as a way of empowering people at the front line to seek help earlier to help avoid those admissions so that people can be treated at an earlier stage in their disease pathway. I'm going to leave it there, but happy to take questions after. Thank you. I've just been reminded I've got one more slide. Here we go. And this is just to say, this is a huge team, and Ray is behind fronts a huge team. There's a big team involved, and I just want to flag up the bottom half of those logos there. So we've got Pathways Alliance, Health Pathways Community, and of course AMA Social Enterprise in Wales. And I'm delighted to see Carrie at the back at the AMA Health Pathways stand. So Health Pathways is about taking guidance, national guidance, and turning it into a form that primary and secondary care agree on locally. It's locally tweaked, but published in a uniform way on every GP and every practice nurse's and every district nurse's device, desktop, iPad, whatever, but making it instantly available at the point of need. And Consultant Connect remote advice and guidance just fits beautifully with that pathway approach. And I hope you'll take some time to have a chat with Carrie and the Yama Health Pathways team at the back. Now, thank you very much.
So just to recap, we have discussed how remote advice and guidance is helping healthcare in rural areas across Wales. And of course, technology is always developing and evolving. And telemedicine devices are the next step in providing state-of-the-art virtual presence, allowing for specialist care to be provided remotely. Although not yet used in Wales, these devices are used in large multi-hospital NHS areas such as University Hospitals Leicester NHS Trust, and they optimise consultant time due to preventing the need to travel between hospitals. And I feel this could be incredibly beneficial in rural areas across Wales in a range of healthcare settings, delivering brilliant patient care whilst also improving efficiencies. So to summarise, remote advice and guidance is available already to all health and social care professionals and patients across Wales, including rural areas. And there's some collateral on your table. So if you're a health and social care professional and you haven't yet used Consultant Connect, please do take one of those. There's a contact email address on there as well. I'm very happy to support and help with any conversations that you may have. Sorry, any questions you may have. And as we've already touched on, the real benefit of this remote advice and guidance is ensuring best patient care, preventing unnecessary trips to hospital, but absolutely identifying those patients that do need to be seen in the secondary care setting, and so on. And as we've said, this saves patients time, money, and also prevents that unnecessary environmental impact as well. And as we've said, technology is always progressing. And Alice has mentioned some developments with regards to health pathways, and also the telemedicine devices can hopefully further support clinicians and patient care in rural areas moving forward. I can tell I've spoken at 100 miles per hour because we've got quite a lot of time left for questions. That's probably due to a bit of nerves at the beginning, but yeah, happy to take any questions that you may have with regards to remote advice and guidance.
Thank you. Thanks for that. I'll start you off with a question that's come up online that's there from Ronwyn. Hello, Ron. Question for Alistair, really. GP bypass numbers. Does this data show that the patients could be educated to contact GP rather than receive an emergency services vehicle in the first instance?
Thanks, Ronwyn. It's a really interesting idea, but no, the data doesn't show that. That would be, I think, beyond the capabilities of the current project to look at that. But that's an interesting one. Patient education and training and carer education and training is absolutely crucial and needs to be an additional tool that we build into this. But certainly, I think that you're right to highlight the WAS data. I think it is extraordinary just how much work that our services in primary care are doing to support the whole system, and we shouldn't forget to highlight that.
Yeah, I think again, coming back to the intervention in the care homes, the proactive interventions, that most probably would create less of a demand on the WAS services in terms of a bigger picture. Any questions within the room? There's one there, if we could go. Thank you. Thank you.
So to ex-public health students from University of South Wales. What you talked about is quite very interesting intervention. I'm kind of trying to figure out how you intend to manage digital literacy and some limitations like diagnostic limitations that might arise. How do you intend to manage that? Thank you.
Thank you for your question. So we spoke earlier about the app and using the app. to place calls, to take images and send messages and so on. We're really conscious that we want the service to be available to all health and social care professionals. So as well as that app, we also have a dial-in number for each organisation. That's a telephone number that they can call from any phone, a mobile or a landline, and then they can select the specialty in a similar way. So, for example, if they were placing a call via the dial-in number, it might say, for example, press 1 for acute medicine, press 2 for diabetes and endocrinology, and so on and so forth. And then the rota works in the same way. So it's really trying to make the service as accessible as possible to those who perhaps either aren't comfortable using apps or don't want to have apps on their own personal phone, whatever the reason may be. We're always conscious that we want to provide kind of alternative routes in to seek the advice and guidance. Cool.
And Alistair, do you want to talk about the diagnostics element in terms of the restrictions of that, maybe?
Yeah, thanks. So just to finish off what Ray has said, that the data that comes out of consultant care is fantastic and it's live. So you can because the service can be personalised down to an individual, to a practice, to a nursing team, to a specialty. So it's you can be very clear what activity is occurring from whom and where it's going and where it's coming from. So you would be able to follow up if you've got a particular concern about whether a care home or a team is able to use the facility, whether it's useful. You should be able, you'll have the data to back that up, and it's produced live and provided for you by the company. So you'll be able to monitor it and audit it as well. In terms of the diagnostics, in terms of dermatology, what I'm informed, I'm not a dermatologist, but what I'm informed by dermatology colleagues, for example, is that actually most phones typically produce a good enough picture to support remote diagnosis, and it's so they're quite happy to support this, and indeed in Betsy Cavalier Health Board area, it is already being used extensively. In terms of the other wider diagnosis and support about that, I think that has to be very much on an individual basis. And at the end of the day, the GP or the nurse making the call, requesting the advice, they're the only one who's actually seen the patient. They're the only one who actually knows what the patient is like. So the governance is held with them. So they're seeking advice, and they have to take that advice and put it in with their own clinical assessment of the patient. So the governance is very clear that you can't hand over governance with a phone call or with a text message. Yeah.
Thank you. Thanks for that. Any other questions in the room? Oh, yeah.
So, I use Consultant Care and it's absolutely brilliant. But I have one bit of additional feedback, is that one of the challenges that I've found within the GP surgery is that it is linked to your NHS Wales email account, which means that when the information comes back into your email account, it's not accessible by anybody else. And I just wonder if there is a way around that, because it can cause problems if somebody is inadvertently not able to access their emails for any reason. But in terms of the usefulness, as a non-dermatology specialist, this is invaluable.
That's what we like to hear. Thank you very much. That's really good. Just to say, in terms of when those who have sought advice and guidance maybe are on leave or unwell, we can work with you so that messages are accessible by relevant people within the practice, if you're working within a practice or within the organisation. So I'm happy to share some more detail with you on that. And perhaps it's something that we can maybe send some comms out in terms of sharing with others how that works as well, so that the message is shared further afield.
One tiny other question, and that is, I was shown how to download it and advised word of mouth how to use it, using Tender, which has worked brilliantly. I have no understanding of how useful any other bits of Consultants Connect might be, and I just wonder whether there is something around the comms around training if you're going to have it, what's the training package that goes with that so that you're really using it properly?
Absolutely. Yeah, I'll take that on board. Thank you very much. Thank you. Which health board are you based in? Haldar. Okay, brilliant. Thank you. Thanks, everyone.
Thank you. Any other questions in the room before I check any online? No. Okay, thank you both very much. Thank you for that. Our next session is at 14:30. So there's a bit of a break there if people want a comfort break, because we've got people joining us from Canada. So we just need to be on time. So we've got a 5-minute break now if anybody needs to have a comfort break. Thank you. Ladies and gentlemen, I'm really sorry for those that have just queued up for tea, but life goes on, I'm afraid. So if we could take our seats, that would be great. Thank you. I need to get my projector on, please. Where's my projector operative? Okay, everybody, if we could take our seats, that would be good. Thank you. Colleagues from Canada are online with us and in full and ready to present, which is excellent timing. And thank you for everybody for the technology there. That's brilliant. So I will introduce now Helen Lightfoot, Sharon Hamlin, Catherine Mellon and Blair Wold, who are practice people from Leeds from Alberta Health Services in Canada, who are joining us online today. Thank you and welcome. They are going to take us through connected people and community for living well for this afternoon. So I'm going to hand over, I don't know who I'm handing over to, but whoever I'm handing over to, it is over to you now. Thank you very much.
Hello, everyone, and welcome. My name is Blair Wold. I am one of the practice leads on the Connecting People for Community for Living Well team, calling in from Canada. So nice to virtually see all of you. So we're grateful for this opportunity to present at this conference, again, as we have the past 2 years. And this year, our presentation will capture the ongoing evolution of our work, the key learnings that have emerged since the start of the project in 2017, and where to next. So just to set the context, as we are in the province of Alberta, here, the healthcare system, it is a publicly funded system. Its coverage for medically necessary services are provided on the basis of need rather than the ability to pay. And social care, it's provided through a combination of government and publicly funded areas, as well as through nonprofit and community-based services. And in looking at the rural context, the population of Alberta is about 4.4 million, and that's spread across a pretty large area of about 662,000 square kilometers, which compared to Wales is 32 times bigger, whereas and the population there is about 3.1 million. And so here in our province, when we speak of rural, it's not uncommon for people to have to drive 2 to 3, even up to 6 hours to get to an urban center where there's the needed services. So looking at the past 3 years, we had a Health Canada grant from April 2020 to March 2023, and that's been extended. But the past work had a rural focus, and I was working with 5 different communities across the province. We were looking at building and sustaining individual and collective well-being in the community, focused on persons living with dementia, their carers, and multi-sector community teams. And how we did this was through the creation of a model that guided the work, applied research, a well-being guide, and a competency framework. So this model was formalized over the past 3 years, and central to it is the focus on building and supporting well-being at that community level. And this includes the well-being of the individuals, so those affected by dementia with the diagnosis and their carers, and the collective. And what enhances the well-being of multi-sector teams is to better support those living in the rural community. The premise being that when the collective is supported, they can better support the individuals living there. Just briefly go over the points here. So provincial support, this went beyond our our grant team and included broader provincial organizations and services that played an instrumental role in supporting sustaining this type of work. Communities advancing local work, this emphasized the lived experience as the experts of the diverse needs at their local level. The 10 core principles, this was the touchstone for both the provincial team and the local teams. The Wellbeing Guide, this was the resource we developed to measure and monitor the impact of the work. And Competency Framework. This outlines the skills and knowledge to work collaboratively and will have a bit more of an intentional focus in the next 3 years. So the model was created to have enough structure to provide guidance and yet enough flexibility to be adapted to each community setting that it's applied to. This speaks to the notion said by Cormac Russell, where when you've seen one community, you've seen one community. So we wanted to take this opportunity to share what we had hoped that each community would come up with one activity, and we were blown away by the 5 communities came up with over 60 activities. So just a bit of an overview, Westlock, they were led by a core group of dedicated individuals who formed the Building Compassionate Communities Working Group. They really embraced hearing the voice of lived experience, and they also had a youth coordinator as one of their leads and helped bridge the intergenerational gap with different programming. The picture here is the mother-daughter, and they made twiddle muffs for the dementia sensory kits that they created. Drumheller, a large focus was on finding ways to connect with those that were harder to reach. So they started by making phone calls to build relationships. And then when the people started feeling more comfortable to attend small group activities, they then joined their larger day program, the Circle of Connection. Three Hills and Nihil County, they had incredible success in growing their dementia-friendly team. It started with 2 members, and with some rebranding and intentional effort, it grew to about 16 members. This included a really strong volunteer base who offered different programs across multiple communities, and they really strived to make the programs inclusive for all older adults. Stony Plain, they have 2 carers on their collaborative, and we're quite intentional on making it a safe space. This is also true of their activities, and the volunteers there were trained to create an environment where both persons living with dementia and their carers could share struggles and receive emotional support. And Innisfail, their collaborative created the Community Partners in Action nonprofit society. They also were successful in developing and growing virtual programming across their online platform, Let's Connect, which offers daily programs for anyone to attend throughout their community, the province, and even beyond. They also developed pop-up programs, which allowed different individuals to commit without a long-term commitment. They also helped access with volunteers. So wanting to share just a little bit about how we gathered information on the impact of this initiative, as there were many partners involved locally and at systems level. Multiple methods were needed to understand the full impact. So this here is what we call our honeycomb. So principles focused evaluation. This looked at the overall initiative, which included provincial support, capacity building, and those core principles. And a summary and final report can be found on our website. The case studies for each community were developed on building connections, shifting perspectives for new approaches. The return on investment, this was up to $3.50 Canadian return on healthcare investments. The social return on investment, the forecast of return across multiple sectors, and we'll talk about a bit more about this in the next slide. The well-being guide, pre and post ratings, was an innovative way involving people with lived experience, looked at the resource challenges and strengths. And evidence of impact. This was those 60 activities which had thousands of participants, resulting in increased social connection, physical activity, brain health, and public awareness. So just in understanding the value of the social return on investment, for every dollar invested in the Connecting People and Community for Living Well project, just over $6 Canadian in social value is created. This exemplifies the benefit for who the work is intended to support. In our most recent work, supporting those with the diagnosis of dementia and their carers. The value to the publicly funded services, which includes the health and social sectors, is 45%. This is equal to the combined value for those with dementia and their carers. It also emphasizes that through using a model focused on supporting well-being, there's still a demonstrated value to the healthcare system. And if you would like a copy or interested in our SROI research, please reach out. We'd be happy to share. I'll now pass it over to my colleague, Katie. Thank you.
Great, thanks so much, Blair. So we had the chance after our last grant to really be able to reflect on all that's really evolved over the course of this work. So through these reflections, we were able to narrow it down to really 8 key lessons learned. So these lessons are an integration of the multiple evaluation results that Blair just went over, as well as through discussions around understanding impact. So these lessons are structured to include lessons not only for us as a grant team, but also for the community teams that we were able to partner with, and for our organization, Alberta Health Services, which is a province-wide health organization of around 140,000 people across the province. So our first lesson is that engagement with persons with lived experience is essential. And what came through again and again is that this isn't just a one and done, but there has to be that meaningful and ongoing engagement, and really right from the beginning of the work. And that can really have a profound impact on decisions being made, not only at that individual level, but within communities and at that system level as well. So from the team's perspective, as well as in the communities, having that voice of lived experience really made it able to inform local needs, which was really important. The second lesson was about well-being, and how using a well-being approach, although it can impact organizations and systems, it's more geared to be able to support those it is intended to, the communities and individuals themselves. A well-being approach also focuses on one's strengths and tries to build off of resources and abilities that are already present, as opposed to just looking at limitations or maybe gaps. The well-being guide that Blair mentioned is a tool that sparks conversations and really is able to capture important discussions about how to support well-being and really how to make those necessary changes to be truly impactful. Lesson 3 was around trust and relationship building. And one of the supporters of our work is often quoted saying, relationships are the currency. And I think the work that happens at the community level is certainly evidence of that, but as well as our grant team and Alberta Health Services as an organization. So building that trusting relationship is really foundational and fundamentally important, and is something that needs that ongoing attention as well as investment. So we as a grant team are really mindful that once that trust has been eroded, it can really take a long time to build it back up, as I'm sure we can all even think in our own personal lives. So an intentional change that we as a grant team have really tried to employ over these past 3 years, and now moving into the next 3 years of this work, is to hear first from the communities that we're working with, since we feel that going in listening has gotten us a really long way, since we're hearing what are those local needs, as opposed to just coming in with our own agenda and pushing that forward. So lesson number 4 is around consistent resources. And I think for those involved in this type of work, or really any type of work for that matter, there is an understanding that there needs to be some type of support and resources, whether it's financial or operational support or personnel, or even just that dedicated time. So we've really seen an ebb and flow in the ability to advance local priorities, as work of this kind has been described by those in the community as being done off the sides of people's desks. So it's not something that is really their full-time job, but maybe one of the many jobs that they do, especially in those rural communities where many individuals wear kind of multiple hats. So an interesting learning from an international conference on integrated care some of our team members were able to attend in the spring, is that globally, this work is not funded operationally. So grant to grant seems to be the norm, and this impacts the chances of building that sustainable, successful, as well as transformative change. Our fifth lesson is around efforts to leverage existing resources supports that sustainability. And what became clear for us as a grant team is that these resources that can be leveraged are available within the communities themselves, but also within our province of Alberta or within the country. And even we found through international experts who are doing similar type of work. So we are trying not only to build our network at a grant team level, but through the diverse representation locally, this helps find new ways to meet local needs by being able to pool the various members' resources together. So sustainability is supported when work is built on existing resources and expertise and bringing those together. Lesson number 6 is around evaluating and understanding this type of work, and that it's best done by using a multifaceted approach, as Blair kind of showed that little honeycomb kind of diagram. So this type of work is layered and can be somewhat complex and a bit messy in a sense. So to understand impact solely through a quantitative evaluation that focuses on emergency department use or acute care length of stay would not do justice to all the other positive impacts that are occurring. So early on in the last grant, we had a bit of a revelation that rather than focusing on one way to understand impact, we really need to understand impact from multiple perspectives and through ways that can sometimes be perceived as non-traditional. And we also need to show impact for the multiple partners that are involved in this work. So evaluation is also one area where communities have limited resources. So we also see this as being a great way to be able to leverage system supports as well. Lesson number 7 is around broad communications of progress and learnings, and really adding to that evidence base of community-led work. So one way we've done this is by holding monthly partners meetings where individuals doing like-minded work can come together virtually, network, build connections and relationships, and share learnings. So one of the other things as a grant team that we tried to hold true to was when building documents, ensuring that they were useful for more than just one audience, such as our team or our website or maybe leadership and the community teams. So we found that this prevents lengthy documents that maybe are not useful for everyone, or sometimes maybe not even really useful for anyone. And although it may go against conventional wisdom, this approach really starts to break down those silos because everyone has access to that same information. And our final lesson is around partnering across sectors and how it supports sustainability. And it really comes back to that relationship part as well. So when there is that broad, diverse representation, not only locally in the community, but also across provincial organizations and sectors, it allows that diverse group of thought to come up with unique ways of addressing challenges and creates that no door is the wrong door approach. So not only at the local level when individuals are maybe needing that firsthand support, so whoever they go to can really connect them with somebody locally who can support them with their need, but also at that program or provincial level to help support sustainability. So this lends itself to the saying that if you want to go fast, go alone, but if you want to go far, go together. So we will spend just the last few minutes sharing the main focus of these next 3 years where we have been the recipients of a new Health Canada grant. This started in April of this year and is going to extend to the end of 2026 or to the end of March 2026. And we're really looking forward to building off the learnings and impacts that we've just shared with you today and that we've learned up to date. So for this next grant, we are still focusing on rural communities, and there are 5 main activities that we will be taking part in. So number 1 there you'll see is sustain. So this is where we will continue partnering with those communities that we partnered with the previous grant to really help support sustaining the work that's already started and helping build off of it. Number two, or that second activity, is to spread this work to other rural Alberta communities. And this is still with that focus on supporting persons living with dementia and carers, but to see if we can adapt or use the same model to support those living in those local communities. Then there's scale, and this is where we will be scaling the model to support additional underserved populations in rural Alberta communities. So we heard in the previous grant from the community teams that they could see where many of those community partners worked not only with persons living with dementia and carers, but also supported other populations within their communities. And we often heard that they could see value in taking this approach to support those other individuals as well. So that's where we will be scaling the model, and this is where we will be doing or conducting another applied research to learn what supports the well-being of additional underserved populations, and then supporting other communities to be able to work through the model to find ways to create those positive impacts. Then there's knowledge translation, and that's where we will continue to find opportunities to share the learnings of this work and to build off of those learnings. Policy and infrastructure, and that's where we're in the process of looking at what policies and infrastructure may already exist locally, provincially, maybe nationally, that help support this community-led work, but also maybe see what maybe needs to be adapted or what's missing that can maybe help continue to move this community-led work forward. And then throughout, we will continue to be doing evaluation, so conducting those formal evaluations as well as doing a formal social return on investment as well. So we just thought we would also share our website. So it's our newly updated website. So there's a link there, as well as there's a way to contact us if there's any interest or any further questions beyond today. And also just to keep apprised of what we're involved with, especially over these next 3 years. And our contact information. So maybe I'll stop sharing and see if we can open the floor for any questions or comments. And thank you again so much.
Thank you for that. Thank you. Again, almost like holding a mirror up to ourselves, really, isn't it? In terms of the picture. Would you believe that they're in a different country, miles away from us, when we're all trying to do the same things that we're just hearing about? It's fascinating, really, to hear that across the world, and I know that Anna and the team in Canada are keeping in touch with each other regarding how we look at each other's story and journey going forward. So I'm going to open the floor for questions, if there are any. If there are any questions in the room, thank you.
Seems to be here in Wales about the role of the third sector and the pressure that the inconsistent resources has, particularly on third sector organisations who are increasingly being asked to support communities and want to support communities. Just wondering if it's the same in Canada.
Just wondering if someone could help rephrase or state that question for us. We're just catching parts of it. Oh, and I think you're on mute. We can see your mouth moving.
Have you heard the question? Did you hear the question at all? Sorry.
Just parts of it. Yeah. So
Just
if you could
parts of it, right, okay.
Yeah.
So the question was around particularly the third sector, around the consistent resourcing that you were talking about in terms of that consistency of resource. And it's something that plays into lots of discussions we have over here in terms of the that inconsistent third sector funding route. Have you had experiences of how that's dealt with over with you?
Yeah, that's a great question. I think as Katie was going through the lessons learned, all sectors are a key part of this work. I think it to honor how people live and function in the world they live in. It takes that collected effort, and the funding or the resource capacity for each one of the sectors is just not there on an ongoing basis. That the reality is that grant funding space, which is good for a short term and not for the long term. So it absolutely is something that we hear, whether it's in the healthcare sector, social sector, community partners. It is a reality for sure. What are the solutions to that? We're not quite sure and are open to ideas, but hoping to tease some of that out in that policy infrastructure work, even in terms of grant funding periods, etc. So anyone else on the team to chime in?
I guess I would just describe in terms of that third sector is it is all basically all nonprofit societies that are delivering those types of services. And so again, they are always looking for funding that way. It must be at least 25% of their activity when you look at their overall budgets, I would think. Yeah.
Thank you for that. Again, it's an interesting ongoing debate as we're moving more and more into that sort of social model for health and care and how that's going to work, isn't it? And I think that's a really, really important thing for us to get more involved in and more of a grip on. A big discussion to have there, I think, going forward in the future, particularly around some of the procurement rules that came in and have come in over COVID in terms of how that's dealt with as well. I think there's a big discussion to have there. Any other questions in the room? Any online? Nothing. Okay, thank you very much to everybody from Canada. Thank you ever so much for that. Much appreciated. Thank you.
Thank you.
Thank you. Thanks so much.
Thanks, everyone.
Okay, thank you all very much for that section. Really informative and a great journey through those presentations. So we're just going to wait now for our pavilion colleagues to come back, and then we'll start off with the plenary session where we have the chief execs of the health boards to talk to us. Thank you. Okay, can we just now sort of take our seats again quickly, if that's okay? Have I got the whole of the pavilion people back again or not? Okay, thank you, ladies and gentlemen. If we could just take our seats, that would be really useful. We're about 3 minutes late into this session, so I don't want to people waiting too long, if that's okay. Okay, thank you, everybody. And now we're going to move into the plenary session where we've got the chief execs of the 3 health boards in the room and online for us in terms of a discussion around plans going forward and some room for questions at the end of that session. We are very lucky to be able to get slots in diaries for this busy time. There's lots of fluidity, which I'm sure will be discussed as we go through this afternoon, in terms of where we're at. So can I just welcome Carol Shillerbeer, Steve Moore and Hayley Thomas, who are here to take us through the health board's plans and also to take open questions at the end of this session. So if we can go through the plans first and then take the questions at the end, that would be really useful, if that's okay. Thanks. I'm going to ask Hayley Thomas to come up first, as she's in the room here with us. And then if I go to Carol and then Steve, if that's okay. Thanks, Hayley. Over to you.
I think it switches off as soon as I look at it. Prynhawn da pawb, diolch yn fawr iawn am y cyfle heddi I gyfrannu'r gynadledd heddiw. Good afternoon. Thank you for the opportunity to contribute to the conference today. We've been asked to reflect today on a few minutes, for a few minutes on our plans for the future as a health board, but also our commitment to working regionally across Mid Wales. So just a bit of a sort of planning context for us. As a system in Powys, back in 2017, we did a lot of work on our 10-year strategy, A Healthy Caring Powys. And this was a strategy that was developed with the people of Powys. And we had substantial inputs from staff, the public and patients, I think about 10,000 responses in total. And that informed the development of our strategy. This strategy still remains at the heart of the priorities we're seeking to deliver as a health board and across the Powys system, and has been adopted by the Regional Partnership Board. The Regional Partnership Board and Public Services Board in Powys has been established for a number of years now, and the work that we've undertaken on the wellbeing assessment and population needs assessment most recently is the basis locally that we use to plan our services. And we've also considered, alongside a lot of the examples today of innovation and best practice, there's a strong national evidence base that we've taken on board to help us understand what the current and future demands on the services will be, a focus on population health, and also making sure that we're listening to people about the priorities locally. We refreshed our 5-year area plan, the Regional Partnership Board, as well as the Powys Wellbeing Plan recently. And the scale of the challenge that we're facing across public services is substantial. That's across health, the local authority, the third sector and other partners. And at an organisational level, some of the issues, not just around financial challenges, around sustainability, but also some of the workforce challenges that we're facing. So just to give you a bit of a sense in Powys, as a health board, we're running a £33.5 million deficit plan at the moment and substantial savings to deliver. And Powys County Council also have a £17 million savings requirement this year. And the fiscal outlook over the next few years is even more challenging. So the council have commenced an exercise called Sustainable Powys, with the aim of designing a future for the local authority that delivers stronger, fairer and greener services whilst also reducing costs. And also the third sector funding, we've just reflected on that. This is not just a national but an international issue around the particular funding pressures that the third sector face, as well as the short-term cycle of annual funding, which causes issues for the sustainability of the sector. So we're working alongside Powys County Council at the moment as a key partner in the development of what we've described as the accelerated sustainable model of care for Powys. And I'll cover that in a slide a little bit later. Just in